reading about what exercises are good and what is not good, or what is better and what is not better. Simple as that. So traditionally, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. I could gather myself. Hello. It is always subjective, and each individual learns the application of the word through the experiences related to injury in early life. So this is what pain is all about. So basically, pain is all about what experiences you've had in life, and accordingly, you will kind of react to it. So the nature of pain is basically, pain is subjective and very highly individualized. Its stimulus is physical or mental in nature. It interferes with personal relationship and influences the meaning of life. Only the patient knows whether the pain is present and how the experience feels. May not be directly proportional to the amount of tissue injury you have always. All right. The purpose of pain is basically protection. So the pain is present basically to protect your body. It prevents further damage. It's kind of a set alarm system. So if there is any kind of a damage or abuse happening, it will produce that alarm. It will give that larger kind of a loud signal or volume, so that we understand and we protect it, preventing the damage of that particular injured area further. So accordingly, as I said, the traditional pain was, according to the definition. The modern pain is multifactorial. It's biopsychosocial. So peripheral factors like the tissue damage, injury, and inflammation, these are the biofactors. Perception, thoughts, emotions, social stress, these are the psychosocial factors. So basically, you have to understand everything to deal with pain. And today we are talking about lower back pain and the leg pain. So we need to actually look into all the aspects like a biopsychosocial model, and then talk about, and then decide how do we treat about it. So pain stops movement. The first response for pain is stopping movement, and that is where we are here for. I mean, how do we move with pain, or how much of movement is good with pain? That's what I'm here to discuss and talk about. So initial response from pain is and seek rest. But at the same time, exercise therapy is often prescribed as a treatment option to manage pain. So we have to understand what kind of an exercise and what kind of movement is good for a specific pain. It has also said that exercise acts as drugs. Many authors have definitely postulated exercise should be considered as drug. Improved pain control is the most important benefit of this particular drug. And if you can see the beneficial effects of exercise in the various systems in the picture, various systems of the body, there is always a good effect of exercise, and that's why it's called as drug. Of course, definitely as a drug, it would have some side effects also, but those side effects are different. So that's what the pain and about exercise is. So let us understand what movement is. Movement and exercise almost go hand in hand. Movement or motion is the state of changing something's positions. So movement affects everything from circulation to digestion to metabolism to immunity. With movement, our bodies regulate hormone activity, detoxify, and respire. Okay, so benefits of movement is the most important benefit is it turns the pain volume button down by accessing body's own inbuilt pharmacy. So body has its own pharmacy, and if you activate the movement accordingly, it will deal with that, and the pain volume button will be turned down. Helps reassures that some pain with movement is definitely okay and does not mean you're doing harm. So as you're saying, even the latest research or literature shows that the pain with some pain is always okay with the movement. That's why we don't, Dr. Vishal is going to speak about it, and the pain specialist, Dr. Mahesh Mohini, both of them are going to speak about all of them are going to speak about it. They will further explain what exactly and how much of pain is good to take and what is not possibly. And movement is definitely okay. So that's why bed rest is totally not okay. I mean, gone are the days where we used to tell, yes, we have to completely rest on the bed if you have pain. For example, if you have a lower back pain, you rest it out. Initially, that was the thing. But as per the literature is developing, as per the evidences are coming out, some kind of a movement is okay with the pain. So you have to protect that part and move it. Keeps you active and capable of doing what you want to do. It helps to regulate the sleep patterns. It reduces stress. It improves mood, improves immune function. Good for your general health. This is what all movement will give you. Helps with the weight control, and good for your brain. Exercising helps maintain a healthy brain as you age. So it is very important. Exercise and movement will definitely help to give you a healthy brain. As I said, pain stops movement. So the movement is basically like relaxing, stretching, walking. It's important for your health and a big part of pain management. But that's not the only part. As I said initially, because we are talking about biopsychosocial way of management. Remember, it has to be remembered that the movement and exercise are only one important piece of pain management jigsaw puzzle. So others are like pacing, care, and belief. These are the ones which you need to really look into along with the exercise and movement, which will help you to deal with the pain properly. Here I would like to introduce a term called exercise-induced hypoalgesia. This is very much come out into the pen medicine world at the moment. So basically, exercise-induced hypoalgesia is characterized by a decrease in sensitivity to painful stimuli with variable duration, lasting approximately around 30 minutes after a single bout of exercise. It's a phenomenon which has been extensively studied in the literature, and results of which are very ambiguous at the moment. Exercise-induced hypoalgesia is poorly understood and is characterized secondary to increase in pain. Secondary, it is basically it increases the pain threshold and the tolerance. It helps in that sense, your pain threshold is increased so that you don't feel the pain, but at the same time, the benefits of exercise will also be there. What's the hypothesis behind exercise-induced hypoalgesia? It's basically central opioid systems are activated by increased discharge from the mechanosensitive afferent nerve fibers A delta and 4C arising from skeletal muscles secondary to the rhythmic muscle contraction. Exercise has shown increase in blood beta endorphin concentrations. Exercise increases serum concentrations of endocannabinoids, which may contribute to control of pain transmission. Actually, the exact mechanism still remains unknown, and a lot of work is going on in that field of exercise-induced hypoalgesia. Effects of different types of exercise in pain management. Pain control is achieved differently with different types of exercises. Prescribing appropriate intensity and frequency of exercise is important in achieving the desired effect of hypoalgesia. So if you talk about aerobic exercises or the endurance training or the resistance exercise or the strength training, these have to be at a proper intensity and frequency. Then only those effects. For example, if you do the aerobic exercises, it basically gives you a good tone into the muscles of the lower limb, basically, because if you're running, for example, is an aerobic kind of an exercise. Similarly, there have been studies showing that the effect of aerobic exercises on pain has been there, but it has to be kind of happening in the region of around 60 to 70% of your VO2 max, which is the oxygen uptake capacity. Similarly, there's not much of a strong literature or evidence present about resistance training, But yes, isometric and isotonic exercises which have been done and were studied, and they have shown to have a moderate kind of an evidence which helps to reduce pain. It's also condition specific. Therapeutic exercises are primary choice of non-pharmacological treatment of chronic neck pain, low back pain, complex regional pain syndrome, and other conditions like fibromyalgia, osteoarthritis, and similar pain syndromes. So Hayden and his team had concluded that supervised exercise therapy, which consists of stretching and strengthening and is individually designed, improves pain and function in chronic non-specific low back pain. So we are basically going to talk about that now. Management of back and leg pain through exercise. The most important is, the recent literature, the recent guidelines which has come out of studies in the worldwide studies, mainly in countries like UK, US, and Australia. These are the Denmark. These are a few studies which gathered, and it came to a common message: is that patients should be reassured that they do not have a serious disease. So education is very important in back and leg pain. So, and they should stay as active as possible, progressively increase the activity levels, and return to work as soon as possible. So it is no more a debilitating condition. It has to be understood that some amount of movement which can be allowed and is not stressing that particular part is not increasing. So that's why I said it has to be the frequency of exercise, the timing of exercise, the amount of exercise has to be educated to them. Similarly, it has to be educated to them that it is not a serious disease and they can stay as active as possible. So that's one of the part. Second, of course, exercise therapy. There's large consensus across the various guidelines that specific back exercises are not recommended for patients with low acute back pain, with acute low back pain, but firm recommendations in favor of exercise therapy in patients with subacute and chronic low back pain. So in acute back pain, possibly as there are no specific exercises which we should be administering, but it should be kind of generalized movement, mobility, as much as they can accordingly, as much as they are capable of doing, they should be doing in the acute stage. But in the subacute and chronic low back pain, definitely the exercise therapy could be planned, and so on and so forth. Other aspects of management are, of course, manual therapy. There is a manual therapy which has got moderate level of evidence because it's more of a passive therapy rather than active. But of course, it does create passive movements. So definitely that is also very much recommended. As a physiotherapist, we definitely do a lot of manual therapy. There is traction, which has got the least evidence, and it has got no basis. It improves the lower back pain and the leg pain. So definitely we should stay away from traction. Electrotherapy, again, a very passive therapy. It may or may not help. So there is no clear evidence in the literature, and it shows that it is not of a big help in managing pain, low back pain and the leg pain. Definitely what the recent literature and the guidelines I've been talking about is about cognitive behavioral therapy. This is the one aspect which is because there is a lot of fear, there is a lot of catastrophe, what they have from this exact syndrome of the low back and the leg pain. They are very so fearful to move. They're so it's that, I mean, they are terrified to move. And that's why they basically kind of restrict their movements, and they're not able to progress further on that aspect of movement, which will help them to really be free, move around, and reduce pain. So behavioral education is also known as the cognitive behavioral theory, encompasses many aspects of patient education and counseling for patients with low back pain. But no specific type of behavioral therapy is superior to another. It's any of them. Of course, it will be individualized as accordingly people would like to do it. I mean, what suits them, and the psychologist how they can deal with it, or the behavioral educators how they can deal with. So it will be nice. As nice, the National Institute of Healthcare, Care and Exercise in UK guidelines suggest a cognitive behavioral approach and exercise is the best way to manage back and leg pain. So looking further, if we talk, when we understand that exercise therapy is the best way forward for the management of low back and the leg pain, utilizing trunk coordination, strengthening, and endurance exercises. Delito et al., they conducted a study in 2012 as part of it, and they came to a conclusion that these are the specific part of exercises, like the trunk coordination exercises and strengthening and endurance. These are the three types of exercises which will be very helpful in managing the lower back pain with the leg pain. Repeated exercises in a specific direction determined by the treatment response to improve mobility and reduce symptoms in acute, subacute, and chronic low back pain with mobility deficits should be considered for sure. I mean, many of the physios who are online and would know about McKenzie method of treatment, and McKenzie method of treatment is basically looking for the treatment response to improve mobility in a specific direction, either flexion or the extension. And then accordingly, we consider that those kind of exercises. Although if you would see further, it also has some, the evidence has, the literature has shown that the evidence is moderate to a medium level. It's a very restrictive evidence which we have about that kind of an exercise. Also, chronic low back pain with radiating pain, flexion exercises combined with other intervention as manual therapy and strengthening exercises will be definitely helpful. Utilizing lower quarter nerve mobilization procedures are part of the exercise therapy. Incorporating moderate to high intensity exercises progressively and very gradual progression are found to be very beneficial to deal with the pain of the lower back. Incorporating progressive low intensity submaximal fitness and endurance activities are also found to be very effective for the specific localized low back pain. So generally, the low intensity submaximal fitness and endurance activities is a whole body activity, but it has found that even that kind of a movement and freedom of movement will help the lower back and the leg pain. So what exercises are the best? Definitely, there is no evidence available to show that one type of exercise is superior to another, but a combination probably would work. A whole body should be working. So if you see, there are exercises like Pilates, yoga, walking, passive exercises like mobilization and manipulation therapies, movement control exercises. There are these new, very much technology supported exercise therapy, and definitely the McKenzie method of mobilization or mechanical diagnosis, as we call it. So Pilates, when we talk about Pilates, an exercise system centering on controlled movement, breathing, and stretching is known as Pilates, as you would understand that. Most clinical trials in the past 5 years have found Pilates to be effective rehabilitation tool that has resulted in desired outcomes such as reducing pain and disability. That's the latest evidence. So the benefits of Pilates is that there are the 6 reasons why Pilates will make you a better life. It can be done by anyone, young or old. It strengthens and conditions the core. It is good for posture. You feel more energized and stressed and relaxed. It improves the mind-body connection. It improves the balance and coordination. So this is a whole body workout. It's nothing about specific to the lower back. But yes, we are concentrating on the lower back. At the same time, we are focusing on different parts of our body also, which will help in turn to reduce the pain in the lower back. So Pilates is the form of exercises which is highly recommended, and in the past 5 years, it has been found to be an effective rehabilitation tool. Getting down to yoga, a Cochrane review demonstrated a slight functional improvement with a slight reduction in pain. So not a great thing, But I mean, I wouldn't say it is, as I said in the, earlier, there is not one exercises which is superior to another, but this is part of it. So a systematic review definitely demonstrated that a slight functional improvement with a slight reduction in pain, yoga is beneficial in that sense. So again, it will depend on how much and how do you do it. So you cannot just depend on yoga. Yoga with Pilates possibly and other forms of exercises is the way forward. Walking, surprisingly, walking was found with low to moderate quality evidence to be as effective as other non-pharmacological interventions in decreasing disability and pain, and was definitely recommended by the study done in 2018. So walking is a big factor, and walking basically, it will give you a generalized mobility, a generalized movement, all everything. Walking, there are lots of benefits of walking, as you say. It of course affects the cardiovascular system, it affects the hormonal system, it affects all your other systems, the respiratory system, everything, which will help you in turn to have a good effect around your lower back as well as the limbs. And that's why it is very much recommended. Mobilization and manipulation therapies. If you see, this is the way a lower back is usually manipulated. A systematic review and meta-analysis of manipulation and mobilization in the treatment of chronic lower back pain, published in 2018, found moderate quality evidence that manipulation and mobilization decreased pain and increased function in a short-term basis. It is, I mean, not a long-term effect, but definitely a short-term effect of mobilization and manipulation is there, and it helps to reduce the pain. So manipulation seemed to be more effective than mobilization, although both were safe to be done, and that was found out from these studies which was done regarding the lower back mobilization and manipulation. So definitely, again, as I said, I would like to stress here again, it's not only these treatments which are going to help, but it is about combination of treatments. So mobilization and manipulation therapies, as it was described by Deliot et al., mobilization therapies, including with strengthening exercises and nerve mobilizations, and a combination would definitely help in dealing and managing the lower back pain and the leg pain much better way. Movement control exercises. So these exercises are selected based on the direction of the impairment, that is flexion, extension, and frontal plane. The first step for patients is to learn to control the position of the movement of the lumbar spine in different postures, such as standing, squatting, 4-point kneeling, and sitting. These are the basically movement control exercises. It's basically, we're talking about core control, just controlling the core, like the transversus abdominis is supposed to be the exercise. Is supposed to be, I mean, till now we have been under impression that transversus abdominis is the deepest core muscle, the muscle which acts as a corset around our lumbar spine, is the most important muscle to be activated and strengthened for good effect of pain management in the lower back and the leg pain. But it is not the only way. So definitely it has been found very low to moderate quality evidence of a positive effect on disability, but pain intensity significantly decreased when you did that. So the intensity of pain does decrease with this kind of movement control exercises, but not completely. They are the only ones. So basically, when you're dealing with an acute or a subacute pain, you would start with these, where the control of the lumbar spine is learned by the patient, and then we add on functionality to that is more important. Movement, completely moving around, mobilizing yourself, moving around in the society is the most important, and the functional movement. So basically, it's not only movement control, but functional movement control is the way ahead when you're dealing with lower back and the leg pain. This is the new one which I've come across, technology-supported exercise therapy. So technological systems such as electromyography, myography feedback provides technology-supported exercise therapy, as we call it TSET, and have been progressed to benefit exercise therapy for lower back pain. A recent systematic review found that TSET improved pain, disability, and the quality of life. But there are limited number of randomized controlled trials. Solid conclusions are still available, and the study is on. So the feedback from the electromyography feedback mechanism would help us to develop further exercise therapy using the technology, and that will be definitely the way ahead to understand what are the best exercises, specific exercises which will help to support the back and the leg pain.
Dr. Vaibhav, we would need to kind of speed up this because
I guess a couple of slides more, not more now.
Great, yeah.
So the other way is the last way. What I'm talking about was the McKenzie method. A recent literature review with meta-analysis in patients with chronic low back pain found moderate to high quality evidence that MDT was superior to other rehabilitation interventions in reducing pain and disability. But the only effect of this study was it was compared to other MDT methods itself. So that's why these are the ways usually the McKenzie extension exercise is done with your arms. If you can see that, press ups to reduce your back pain. I'm just going to rush through them. When performing, if it is an extension based, you do the extensions. If it is a flexion based, you do when performing exercises in sitting position. If you think that flexion is the movement, what you're looking for on your assessments, they have a different way of assessment. As you know, McKenzie method, the MDT, they have the way of assessment is also different, and those exercises accordingly are discussed. I won't spend time on that video at the moment. We will go ahead. So in conclusion, lots of different types of exercise have a positive effect on low back pain. No one type seems to be superior. Focus on the human being, not just the back. That is more important way you take back from this topic, from this webinar, from my talk. Exercise that people enjoy and easy for them to do will probably get done and hence have a positive effect. Consider a rehab program combining different exercise variables like high and low load and types rather than one singular type of exercise method. Deconditioning is not clearly associated with low back pain. So the studies have found out that positive effects from exercise for low back pain may not be directly attributable to things such as strength, mobility, and endurance. Increased trunk stiffness and decreased range of motion and speed of lumbar movement are associated with low back pain. Structural factors such as lumbar lordosis, pelvic tilt, leg length discrepancy, and muscle length are not likely to be associated with the low back pain. Kinematic and intramuscular reduction in variability is associated with the lower back pain. Decreasing stiffness and promoting freedom of variability of movement, a good goal in rehab, especially with those displaying gynosophobia, which is fear of movement. So in current practice, what is being followed, it's physical exercise, physical, that is exercise, psychological, that is cognitive behavioral therapy should be tried before pharmacological investigations for lower back and leg pain. Multidisciplinary treatments are recommended. Finally, in lower back pain, the physical therapy exercise approach remains the first line of treatment and should be routinely used. Okay. That's it. I mean, is there a right type of exercise? No, you have to, it's not one size fits all for an exercise. When you prescribe an exercise to an individual who's suffering from the lower back and the leg pain, it has to have various aspects. It should be good for your health. It should include relaxation and stretching also, strength and conditioning, and balance and agility. So that's what it is. Do more movement is my tagline in the end. As a matter of
unfortunately, it comes at a time when the government wants nobody to move around.
Do more movement at home.
So thanks for this lecture, and I'm sorry I had to interrupt you there, but we're trying to stick to time. But I
No.
see a lot of physical therapists and occupational therapists and professionals on board here. A small request. I saw a couple of raised hands by Dr. Sampada Joshi, Dr. Kavita, Dr. Naina. I'm sorry we can't, get them here. What I could request is if you see the Q&A box at the bottom of the screen, please type in your questions there, and Dr. Vaibhav or whoever, one of us can keep taking that, so that we will go ahead with the next part.
Yeah, definitely. Yeah. Yes.
Yeah. So, and whatever questions we cannot answer, we'll probably be sharing it with you, as I said, in the next 24, 48 hours or so. We'll try and keep the discussions a little towards the end. So I will unmute a few of us so even the attendees can speak and we can have a direct conversation. We just quickly move on to the next slide. And I'm sure I'm going to run through my slides as well, Dr. Mohini. Mohini, take it away, Mohini. She's going to talk about dry needling. So if you raise your hand, the icon, the hand raise hand icon, I might not be able to allow you to speak for some time right now. But as I said, please type in your questions in Q&A. Otherwise, we'll get all of you to speak at the end, please. Thanks.
Sir. Slides are visible. Hello.
We can't see your slides, Mohini.
Now?
No, we still can't see your slides, Mohini.
Can you see?
No, you started the screen share, but it doesn't show.
Just a second. Now can you see?
So here's
Have
what
you started a slideshow on your end?
So you've started a slideshow. It's all right, Mohini. What I'll do is let me share the screen here. Yeah. Let me do that. Yeah. Is that all right?
Yeah. Now we can see.
So I'll be your assistant for this presentation, Mohini. Just keep telling me next.
But yes, sir. Yes, sir. Can you see, sir?
Yes, we can see it. Can you see it, Mohini, on your screen?
Yeah, I can see, sir.
That's so we are reflecting my screen, yeah?
Yeah.
Say hi to your daughter in the background.
So topic for today is dry needling for axial backache. Am I audible, sir? Clearly?
Yes, you are. Thanks, yeah.
Okay, sir. So what key points we are going to address today are why to treat muscles. In short, I will explain about muscle physiology, then mechanism of muscle pain, myofascial pain, then how dry needling helps in myofascial pain, the basic concept and scientific basis, and which muscles to address in low backache. So there are 640 skeletal muscles in our body, which comprise nearly 50% of our body weight. So why should we study muscles as pain generators? So here comes the Hilton's law. A nerve supplying joint also supplies the muscles that move the joint and skin overlying the insertions of these muscles. This is called Hilton's law, very famous law in anatomy, which we studied in first year. So muscle physiology. So there are many muscle fibers which are individual cells of a muscle, and in those cells there are actin and myosin filaments, which are thick and thin filaments which slide on each other so that the muscles contract. For this contraction and relaxation, when the action potential comes at the neuromuscular junction of a muscle, there is excitation contraction coupling for which ATP is required as an energy source so that the muscle contracts as well as relaxes due to movement of calcium to and fro from sarcoplasmic reticulum to the cytosol of the muscle fiber, which is the muscle cell. So this is the reflex arc. So afferents from muscles go to the spinal cord and efferents go to the muscle. So we have to study two properties of a muscle in the physiology. So first is the inverse stretch. First we learned that is energy is required for whether it is muscle contraction or the relaxation. And the second property is inverse stretch reflex. So harder the muscle is stretched, stronger is the contraction. So whether it is passive stretching of the muscle or dry needling, whatever, we will come next in this topic. So, however, when the tension becomes great enough, contraction suddenly ceases and muscle relaxes. This is called inverse stretch reflex. So, stretching of the muscle, there is a contraction. When the stretch becomes uh, high enough, there is activation of the receptor, that is Golgi tendon organ, and the muscle relaxes. That is called inverse stretch reflex. So these are the Golgi tendon organs in the tendon of every skeletal muscle. So we are going to come on the topic of dry needling now. Changan first presented this dry needling as a modification of acupuncture. So again, we are going back to the muscle physiology and pathophysiology. So what are the taut bands? Which are the taut bands are the contracted muscle fibers which are readily palpable, and a tender point in the region of a taut band is called as myofascial trigger point. Sir, am I audible? Hello?
Yes, you are audible. Thanks.
Yes. Okay. So what is the etiology of these myofascial trigger points? So obviously direct trauma to the muscle, then myalgia in occupations needing low level of muscle contractions, means continuous sitting job like in IT professionals, computer workers, diamond workers, then acute and repetitive or chronic muscle overload like the weight carriers who carry weights in their back, on their neck, then postural stresses, then ligamentous laxity with large joint dislocations or subluxation, then all these vitamin deficiencies and hypothyroidism. And these are all nociceptive uh, sources of pain and neuropathy, every type of neuropathy leading to myoneuropathy according to Hilton's law. So these are the various conditions which include herpes zoster, CRPS, neuropathies, visceral pain, phantom limb pain, neuralgias, and inflammatory pain, which is low back pain. So what happens after these nociceptive and neuropathic, myoneuropathic, myofascial trigger points when the trigger points are formed? So there is energy crisis theory of Travel and Simmons, which says that many contracted muscle fibers, that is myofascial trigger point. So as there are many contracted muscles, the energy demand of these muscles is increased as there is continuous contraction. Also, there is compression of blood vessels due to contracted muscle fibers. So there is shortage of ATP and impaired calcium pump, which leads to lowered threshold of nociceptive nerve endings. Ultimately, these trigger points become peripheral individual sources of persistent nociceptive input. They excite muscle nociceptors like A delta and C fibers and induce peripheral and central sensitization. So how does dry needling help in these myofascial trigger points? So first mechanism is, after we do a dry needling to a particular muscles, we insert a needle in a muscle, there is sudden contraction of muscle fiber in taut band, which is elicited as local twitch response, which causes sudden stretching of the muscle and activation of Golgi tendon organ. So as I told you first, there is inverse stretch reflex activation and muscle relaxes. Second is local twitch response causes increased discharge leading to decreased. There is sudden muscle contraction, so more and more acetylcholine at neuromuscular junction is utilized. So there is sudden crisis, sudden decreased level of acetylcholine, so that further contraction of muscle ceases and relaxation starts. So that there is significant reduction of substance P and calcitonin related protein. Third mechanism there is increased muscle blood flow. As the contraction relaxes, the blood vessels uh, start dilating, and there is increased oxygenation, increased ATP. All this phenomenon occur, and the muscle relaxes. Repeated dry needling also upregulates expression of hypoxia-induced factor 1 and VEGF proteins, which promote angiogenesis, vasodilation, and increased capillarity. These are main three mechanisms. Also, there are many other mechanisms like swirling of the needle causes mechanical uh, breakage of the bands and release of other endorphins, all that. So these are three mechanisms which I feel more important of dry needling. So in low back pain, how do we do dry needling? And why we do dry needling? As I said before, so there is Gunn's radiculopathy model when the free flow of muscles is interrupted. For example, in prolapse intervertebral disc, there is due to this compression, there is nerve root irritation. So the impulses, normal impulses to the nerve is interrupted, which causes all innervated structures to become highly irritable, supersensitive, and atrophic. And depending on the nerve, which is sensory or motor or autonomic, these effects are displaced. So, which muscles we do in the low back pain? So, these are some diagrams I have put. So, the after skin, superficial fascia, fat layer, there are muscle layers. So, you have to see the lower half of the this picture. So, there is a big diamond shaped thoracolumbar fascia, which continues as latissimus dorsi. This is the first layer of lower back muscle. Below that, on the right side, if we cut the latissimus dorsi, we see serratus posterior inferior muscle, which is the second layer. Below that is the third layer, which we call the erector spinae muscle. So these are continuous from the sacrum till the cervical spine. So erector spinae muscles has three layers: iliocostalis, longissimus, and spinalis. Then deeper to that are the intrinsic muscles of the vertebrae, which are multifidus muscle, rotators, interspinalis, and intertransversae. Then further anterior are the quadratus lumborum muscle on the both side of the uh, spine. Then further anterior are the psoas major, minor, and the iliacus muscles. Then again, we come down. These are the gluteal muscles, three gluteal muscles. The piriformis, very important muscles. The gemelli and uh, internal and external oblique muscle. Then comes the hamstring and calf muscles, and these are the anterior compartment, quadriceps and tibialis anterior, external hallucis longus, etc. So these muscles we have to do. In case of axial low back pain, we have to do only the low back muscles like this. And in case of Radiculopathy, we have to go further down to the gluteals, the hamstrings, if the sciatic nerve is involved, the anterior compartment muscle, if the upper L2, 3 femoral nerves are involved, and the adductors also. So which needles we use? These are the acupuncture needle, very fine spring-like pointed needles, which are 33 gauge. The sizes are from 12 mm up to 120 mm,
You need to
125
be a
mm.
little louder, please. There is a request.
Yes, sir. Yes.
Thank you.
So there are 4 techniques of. Sir, am I audible now?
Yes, please. Yes.
Techniques of dry needling. Uh, Various clinicians do various types of dry needling. Some do only trigger point dry needling. Uh, Others do taut muscle dry needling. Some others do referred pain and paraspinal dry needling. These are 4 approaches. But why entire muscle dry needling is important? That is more important because the trigger points are not always easily localized. Also, there are latent trigger points which are not palpable. Third point is trigger points can powerfully disturb normal motor function not only in the same muscle but also in functionally related muscles, and there is widespread referral of pain. So we should do entire muscle dry needling. So how to do? Uh, Few patients which are more sensitive, we have to apply the Prilox cream, though it does not penetrate beyond the skin, but it gives some relief. And after that, after all aseptic precautions, we have to put the needles according to the thickness of the muscle and depth at which the muscle location is expected. Then we keep those needles there for 30 minutes, and then after removal, after cleaning with spirit and all, we have to apply ice packs for the local inflammatory reactions, and immediate passive stretching of the muscle is recommended. So these are some pictures for paraspinal dry needling of low back, gluteal muscles, calf muscles. I don't have many pictures for this. So in conclusion, I would say muscles are pain generators, often ignored, but huge contributors in chronic pain. Myofascial pain is not a separate entity but coexists in almost all nociceptive and neuropathic pain syndromes. Comprehensive pain management entails not just pain relief but also restoration of functions. An easy, effective, safe, economical solution is dry needling. That's all. Thank you.
Well, thank you, Mohini, for that presentation. And I don't know. Thank you once again for attending this, for doing this, because we know you're not well and you're. But
Thank
thank
you,
you
sir.
for this.
Thank you for giving me this opportunity. Thank you, sir.
So we have Dr. Nisha Mehta who's raised a hand. I'm just going to request Dr. Ki. We have a question also. All right. So Mohini, you need to answer the question by Dr. Swapnil Mate in the chat box. So you'll be able to
Yes,
see
sir.
it because you're a panelist. Please answer it,
Yeah, yeah.
and we'll just take it. A quick request, Dr. Vishal, do you want to do your presentation first, or shall I finish mine?
However, it's okay with you.
Sorry.
Whatever is okay with you.
Okay, I'll just run through my slide in the next 5 minutes.
Go ahead, Mesh. Do
Okay,
it.
thanks. So we've seen the first part where Dr. Vaibhav and Mohini have been talking about back pain and the muscle component, which many of us as therapists and pain specialists, most of us are aware of it and we do see it. Now, one of the points that Dr. Mohini mentioned was how these muscles tend to go into a sort of spasm and generate trigger points because of irritation from within. Now, one of the sources that we have a simple algorithm to approach these patients in back pain. I'm just going to show you about the injections. So now, what do we do as pain specialists in back pain and leg pain? Am I visible?
Yes, Mesh.
Perfect. So just injections in back and leg pain, no conflicts of interest. Now, a simple algorithm is you have a patient who comes to you with pain. So you just localize where it is. It's in the back or which is loading, or is it related to pain that's going down the leg and there are neurological signs? So the mechanism slightly differs in both, although it's not a clear-cut dichotomy, there is some overlap. So you're looking at the axial structures like the disc, facet, and the muscles there, or you're looking at all of the above along with nerve root irritation and involvement of the dorsal root ganglion. So a quick run through the anatomical part for the lumbar vertebrae. That's the disc here. That's the vertebral foramen in which your precious cargo lies. And you have the disc coming out and irritating this area. And that sets up a strong inflammatory response. As we say, there are multiple factors which I'll probably just skip through because it's related to multiple factors, extrinsic, intrinsic properties of the disc, leading to mechanical changes. And finally, at a molecular level, there are changes that lead to sensitization. Different aspects work on these areas. But if you notice that physical therapy, getting patients back to movement, works on different levels of the pain pathway. One of those interesting points that Dr. Vaibhav raised and about mobility, and I have a feeling how it influences the motor cortex and it helps in pain perception. The take-home message from the first part of this talk is that inflammation and sensitization may play an important role, and muscles express these pains. And there is a space which is a potential target to approach. This is a patient who's 160 kilograms light, and he has pain in his low back radiating down the leg. No neurodeficits, but he's unable to walk or stand for more than 2 minutes. So we took him to the operation theater. We placed him on his stomach and injected the low back region with the needle that you see here. That yellow line which I have drawn is the nerve root. And this is the injection. So you see that these epidurals are very accurate because they are positioned exactly at the site of pain and they are fluoroscopically guided. Now, patients normally ask us, will I be paralyzed? What if I don't know if the pain is there? Is it a painful procedure? So the answers to all of that are no. The risks of complications are very rare. And whatever risks of local anesthetic, steroid, or radio contrast use are theoretical. The biggest risk is failure. In the sense, patients come with a huge burden of expectation that if they're injected, they're going to get better immediately. But it takes time. And we, to a large extent, depend on the kind of rehabilitation that accompanies the injections. This is this gentleman after about a few weeks, and he's right now, it's been a couple of years since I've injected him, he's still doing fine. I'm just going to run a quick video about a lady who's injected with an L3-4 problem. And you can see that she's walking with assistance because she was totally bedbound. She had to pass urine actually by the side of the bed, or she was in a lot of distress. So this is 3 weeks after the epidural. And this is a surprise video that I took around 6 weeks after the epidural. And if you notice that she's actually worn a sari, and she's worn a maxi with a belt around. Now she's worn a sari because she's comfortable doing this. So these can be quite rewarding procedures in our patients. So the benefits of these injections are not just pain relief, but we're trying to return them to function. And this is for patients with leg pains rather than just axial back pains. So these are the green flags, or the areas where your patients who are good for it. And there are some red flags, and I'm sure Dr. Vishal will be talking about the red flags in his part of his speech. Going back to the axial structures, one of the injections that we do is called facet joint intervention. So you see that the loading compartment, the 3 compartments, the disc and the 2 facets, the anterior and the posterior parts. So the facets take a lot of load, and they are supplied by the median branch of the dorsal ramus that innervates the facet joint. One of the strategies that we have is to target this facet joint by doing what is called as radio frequency thermal ablation. So we put in because for your knee joint, you have knee replacement, but for your facet joints, you don't have anything there. So if you see the nerve to the facet joint marked in curved black arrows, this is the location of the nerve to the facet joint. And you can see the needle here, which is placed on top of this nerve, and we apply a current of about, for 70 degrees, we get the temperature to about 70 degrees for 90 seconds. So they are called disruptive, not destructive. So we disrupt the nerve conduction in these areas and get good results. This is the nerve to the facet joint, and this is the area where we ablate so that the facet becomes denervated and the pain reduces, and then they can go on to do physiotherapy. For example, these are patients with severe back pain, and this is post-procedure. Just wanted to share an anecdote. This is my first patient that I had done in Kokilaben Hospital about 9 years ago, and she's still fine. She's now in the US living with her family, and she does yoga. She's 91 right now, and this is one of the pictures that I had taken. I was a lot more enthusiastic, had a little more hair then, but this is a very rewarding procedure for our elderly patients with degenerative spines, with operated spines where the facet is taking a lot of load, and they have axial backache, which is not amenable to a lot of treatment. So if I were to summarize the whole topic, we approach patients depending on what pain predominates, if it's axial backache or leg pain, and the whole purpose of doing a different interventions. So these are just some of the basic interventions. There are many other interventions that we do, but these basic interventions target getting back to function by helping these patients break the pain cycle and get on to the next step, which is therapeutic exercise or different ways of administering physical therapy, occupational therapy, and rehabilitation for these patients. So thank you for this, and thank you for your time. I'll just get Dr. Vishal on board now, and we'll try and answer questions as we go along. I hope this is useful. Yeah. Dr. Vishal, all yours.
Ramesh, Mahesh, can you hear
Yes,
me?
we can hear you, and your slides are visible. Yeah.
Hi, good evening. Okay, most common causes for back pain, all of us are aware, would be sprains, discal pathologies, bony like fractures, osteoporosis, arthritis, infections, or tumors. Well, muscle and ligament sprains are the most common. Probably 70 to 80% of all back pains come because of this. Unfortunately, they are the most treatable causes. They go away in a couple of weeks, if at all they stay that long. The ones we deal with more commonly as medical professional handling back pain are going to be discal pathologies and degenerative changes. Fortunately, I mean, I and Mahesh, we just analyze our numbers. Out of every 100 patients who come to us, 96% get better with just analgesia, rehabilitation, and occasional intervention. So our surgical rate for herniated disc is as low as 4%. In a day, if you're seeing 10 patients, we barely manage to operate one a month. And that's how it is the world over, because pain therapy and physio rehabilitation has become so good that the chances of a patient requiring surgery are not there. Unfortunately, of this 96%, we're going to get okay with rehabilitation and pain management. Only 80% will come back in the next 2 years. Majority of this happens because of usually a patient will follow religiously your advice for 3 months, if you are lucky 6 months, but afterwards they'll go back to doing the same mistakes they've done, and then because disease is precipitated again. Well, back pain would cause herniated disc, will cause mostly leg pain with an occasional back pain. The red flags to remember is, of course, cauda-equina syndrome. If you have a patient who's paralyzed, mind you, these may be walking patients, but will be having foot drops, will have lost their bladder ball. This is, of course, cauda-equina syndrome and is an absolute emergency. But one of the red flags to observe is we have, in the past 2 years, stopped operating patients with mild deficits. Say you have an extensor hallucis deficit of grade 4 or grade 3, and which is static, the pain which is controlled with pain management. These are not patients who require discectomy. We have patients with up to 90% occlusion of the canals who have after a year come with MRI showing a very clear canal, because nature absorbs the disc. That's what's been happening for millennia. It's just now that people are in a hurry. They want to get okay faster. But you have to worry about, like, you had a patient who had no weakness and he got a grade weaker or 2 weaker. Or you had a patient with mild weakness and now has progressed to moderate weakness, or his pain has gone up on conservative therapy. These are the ones you have to worry about. Or those who come back again and again and again. So how much is enough? Usually more than 3 episodes in a year's time is a red flag. If somebody is coming to a hospital or to a therapist for 3 times in a year for back pain, that's something that probably needs to be investigated and probably managed more aggressively. Well, what is failed conservative management? When does a person come for surgery? I'm a surgeon, so I need to talk more about surgeries. Well, he has to have at least 2 epidurals which have not worked for him. The disease process has to be treated with good scientific rehabilitation for at least 3 months. There is no one who's going to be building up muscle mass and getting his tones proper in a month or 2. So this requires a proper rehabilitation of at least 12 to 18 weeks. Well, if there's deterioration while he's on proper management, and there are multiple episodes of pain, like I said before, in spite of being treated well. When in these patients, someone like this is a patient who was operated by my teacher way back in 1989, the year I entered medical school. He got a reherniation again. He was a fisherman. You can see this incision here and the fibrosis that's happened. This was a surgery done in 1989. And my boss is, of course, now 90 plus, isn't practicing anymore. So he sent that patient across to us 2 years back. What you see here is a reherniation. This is what we took out. And this old scar, and I'm sorry, and this is his new scar. So, of course, surgeries also change. Initially, there would be what is called as classical open surgery, which is not very outdated. I mean, people do it probably because they are not retrained themselves. But the present belongs to minimal access surgery. As you can see, or even a revision surgery. This fisherman initially, after his first surgery in 1989, was stopped from going on a boat and fishing. So he started selling vegetables. The only question he had asked me at that time was, Doctor, me kamit kami bhaja tari vikin ka. And of course, within a month's time, he went back to that. That would also required good rehab. But this is 2 years old and is still doing what he wants to do. Well, fractures, majority of them, where there is no instability, where the height of the bone is not lost, where up to 50% can be conserved. This is a very big and controversial topic, and the time in the lecture is not, and scope of this talk is not going to cover that. But yes, surgical fixations can be done for some of them where the neurology is threatened or the stability of the spine doesn't work, is compromised. And of course, coming to the most important part, that is degenerative. Well, everybody, I see a lot of people in their 40s and 50s coming and say, "Hey, doctor, I did an MRI, I have a bad disc, I got a facetal arthritis, and I've got a degenerate, desiccated disc, I've got a small bulge." Well, everybody who's above 40, including me, will have a degenerated disc. It's like having your first white hair after 40 years. That's a natural progression of life. If somebody finds a cure for that, they will find cure for immortality. And fortunately, majority of them will get better with medications like the previous lecture, dry needling, facet blocks, epidurals. So all in all, about 80 to 90% of degenerative disorders presenting in the hospital get better with conservative management. Well, what are the red flags? We need to understand this. I see a lot of patients coming in. Doc, we did rehab for 2 to 3 years, and now I'm coming. Unfortunately, in this 2 years, what has happened is that claudication distance has gone below 15 to 20. They're not able to stand beyond 5 to 6 minutes. They're not able to walk beyond 5 to 6 minutes. On an average, with an average pace in 10 minutes, you should be able to cover 1 kilometer. A basic requirement of life is that you should be able to walk 2 kilometers at one stretch. You should at least be able to stand for half an hour without discomfort. You should be able to sit for another half an hour without discomfort. So these are the things that you need. The simple test is to ask them to walk between 2 best bus stops, which are usually 1.5 kilometers away. Because if you can't do this, you will not be able to do your activities of daily living. This restrictions are, of course, for the elderly, 70 plus. You cannot have a 40-year-old coming and saying, Doc, I can't walk for more than 30 minutes or 1 hour. A 40-year-old is, of course, expected to walk more. So age-related appropriate activities should be possible. If they're not possible and there is a degenerative disease in the spine, that's a red flag. Of course, loss of bladder bowel control, again, like Cauda-Equina syndrome, is an absolute emergency. Well, multiple falls. A lot of times people do not agree, they are in denial. They say, Doctor, I was walking and I just keep falling. Most of them comes with fractures of the distal and radius, and when you ask them, you realize that they have canal stenosis, which is making them fall again. Most of them have an imbalance of posture, aesthetic. They are stooped to one side. There is a kyphoscoliosis. There's a lot of muscle wasting in the calves and thighs. And as they walk, they start to bend forward. The reason they start bending forward is because as you flex the spine, the canal diameter gets bigger, and they're able to walk that extra minute. So these are and of course, people who come saying that I can't even sleep, the radiating pain goes down to my leg. This is probably the last stage of compressive neuropathy that you're going to see before a frank deficit comes in. Well, surgical options, the conservative treatment, of course, is beyond my ability to talk about. It's already been spoken about. Surgical is, of course, either when the situation is stable, as in there is no listhesis, the facets are okay, it is just the ligamentum flavum and discal stenosis, you decompress. Where there is instability, you fuse. You can either do it open or minimal access. Like this was an 81-year-old gentleman, he's 93 now. He was on a pacemaker, restricted to his room. That was his state. This is a CT scan done. You can see there's a complete block at this area. And then again, it opens up here. So he had a pacemaker, so we couldn't do an MRI for him. So at this black area here, it shows a complete block of his now at 4-5. He developed a bladder bowel involvement, and that's when he agreed to surgery. It was a small video. The basic complaint of all is like when you do minimal access surgery, you can't see. What you're seeing here, that is the head end, that's the medial aspect, that's the foot end, and that's the surgeon's side. That is the dural sac, and this is the opposite side. That's the dural side there, and that's the ligamentum flavum that's causing compression. I'll take you to the end point. The decompression has to be that good. You should be able to see the disc of the opposite side completely clear and free. That's the point of a decompressive surgery. That was his X-ray when we operated him in 2010, I think, and now it's 10 years old. He's still alive, 92, and walking around. Well, this is another patient. This is where we fail as doctors to convince our patient. The fear of surgery is so bad that this 67-year-old lady, you can see here, is a grade 4 listhesis, morbidly obese, 8 centimeters from anisotrosis to the skin, and that she was in her house for 6 months. She refused to get operated. Finally, she came in because she couldn't even walk to the toilet. That's what we did for her. This surgery is about 5 years old now, and she's been able to move around since that time. How are we improving this? Well, all of us use Google Maps to reach our destination. It tells us what is the best way, what are the other possible ways, and even in the best way where you're going to get stuck. Well, now what we use at our institute is this. This is an OR. Essentially, what it does is it scans the patient after he has been positioned in an operation theater and sends this scan to these 2 screens and the machine here, what's called as a navigation. So this navigation gives me a virtual image of what I'm doing. So how does it help? I'll take you to the surgical videos. So after this image is acquired, it gets transferred to the screen. Traditionally, you will have a surgeon looking down at the patient. But when we do this kind of surgery, we look at the screens because whatever we are doing here is transmitted here. This is our operation theater number 5 at the Mani Hospital. So essentially, I'll just show you what on live. This is me operating, and this is a virtual projection of what I'm doing. This needle I'm using like a drill is this blue thing here, and the yellow line is the projected path that it is going to take. So putting it on the skin, you can see it's on the skin here, and I'm checking what is the path I need to put in a screw. Once that is done, yeah, We determine the areas from where we will enter. Then again, this is, I apologize for the audio, I've not taken it out. So that's the needle going in. You can see the virtual trajectory. The advantage of this is I don't have to cut open the patient through a very small finger breadth size cut. I'm able to put in that needle. You can see it's landed on the bone here. I then check how long the screw is going to be and bang that needle in. So it has become that easy. You can see there is no blood around here. The blood loss is very 50 to 100 cc. If at all, it's going to be that much. And it's as safe as that. You know exactly where you're going. Of course, we are able to see all the instruments we put in subsequent to that. That's a tab going in, that's a screw going in. So all these insertions are under vision by real-time navigation. This is in the cervical spine. What you're seeing here is the cervical spine. We are drilling into the bone in the cervical spine. This is in the thoracic spine. This is what is called as a leg gear shift maneuver. So it's essentially what it does, it makes passage even in difficult anatomy very easy. It shows you what you're doing. So the chances of messing up or having errors, which is usually 6% in human hand, goes down to 0.03%. Well, this is another video. I'm going to skip this. So this makes this is a 70-year-old gentleman operated outside for a failed laminectomy. You can see the screws. He was having a scoliosis. Now that is a completely unacceptable posture, which has been corrected. This is now nearly a year, and his ambulatory out of his deficit. This another 80-year-old, previously operated 4 years back, wheelchair bound after that, corrected here. That's this person walking at his native place in Assam. They sent this video after when 1 year was done. I'm just going to go back to show you the date of his birth. That's 1939. He's 80 plus, so it's getting more and more refined. So they're able to do difficult jobs in the elderly. One of the other common cause of pain is, of course, osteoporosis. Medical management is the mainstay, and an endocrinologist should be the primary person teaching it and not an orthopedic surgeon. Unfortunately, where the orthopedic surgeon is unavailable, that is rather an endocrinologist is unavailable, is the place where an orthopedic surgeon should step in. So if you have somebody with osteoporosis, please see that they get referred to a proper doctor, which is an endocrinologist. Majority of fragility fractures fortunately heal with newer drugs like teriparatide and in some cases denosumab. We do minimal interventions like vertebroplasty and kyphoplasty as the last resort, because whatever others might tell you, you're actually putting hard cement in soft bones. So you do it as a salvage procedure and not as something that is to be used loosely. Of course, surgery is required. Like in this lady, this is a very common X-ray we see. This is you can see the small line here. That's a non-union in a compression fracture. And that's the end point of the surgery where the bone was removed, a cage put in, and that's what you see. And that's the 3D, this is some interesting 3D reconstructions. These are the three planes that you see in a surgery. So this cage is put inside. That's the canal of the vertebra. That's the lung area. And that's the entry path. So we've not opened the spinal canal here. So this has ensured that the chances of paralysis are very low. At the same time, we're not gone through the chest. So the chances of having a lung injury are low. That's how safe surgery becomes nowadays. And of course, that's how the intraoperative vision is. That's the implant with its bone graft. So basically, surgeons have remained the same, but the technology has made us look wiser. And of course, Gandhiji had his 3 monkeys. Now we have the 4th monkey with a mobile in our hand. So spine surgery has maybe 110 monkeys that after a spine surgery, you cannot sit on the floor, you cannot squat, you cannot do any high impact activity. Just to illustrate a point how far it has gone, this is my first surgery I did 3.5 years ago when I joined Ambani Hospital. 75-year-old, high-grade listhesis, syndromic rheumatoid arthritis patient. That is the surgery that was done for her. Basically, these are the images. We did it through a tube, minimal access, and that's her sitting and squatting at 1 month post-surgery in the outpatients. Well, it is a lot of myths about spine surgery, about what has been done. Fortunately, the need for surgery is extremely low as compared to the patients who get better with conservative management. I mean, we're now documenting our results. Discectomy rates are only 4%, and majority of the, if you are operating 4 out of 100, majority of them were actually told that you need surgery. 90% of these came because they were told surgery somewhere outside, and they didn't require it. And that's how low it's really required. And unfortunately, if you still do need it, it's not so bad. I mean, the results are good. We have people who've gone to playing back professional level cricket and Olympic level tennis and done well there. Of course, regular course active lifestyle as is required is also possible. But my boss used to say, we have the easiest job. The difficult job is to get a patient who's got operated back up and running. That usually is taken care of by Vaibhav and his team. Thank you. Thanks for your patient hearing.
So first of all, I want to thank all of them for taking time off. And as you see, Dr. Vishal is still in the hospital. He was seeing patients till now.
It is not, I think all of us are just sitting Vela now. But it's, it's a beautiful day outside, actually.
Yeah. In fact, one of the problems with COVID right now is that a lot of our patients with back and leg pain, and I'm sure that the therapists here and all the surgeon here, all of us agree that the patients who are sitting at home right now are being are still going back to those I would refer to them as the bad old days of bed rest, because they are being told to take rest at home. And the whole purpose of having this sort of a brainstorming session was to start off with Dr. Vaibhav talking about how movement is important. And I'm sure all therapists do agree with this, and kind of also expand on the concepts that we can have different options like dry needling. There is a question on there's another question on dry needling for you, Mohini, if you could just answer it by Dr. Neha Kamble. So there are different aspects to this process, that there are injections that come in, and as Dr. Vishal rightly said, many patients get better with conservative treatment, and after that there are patients who don't do well with injections and they have to go for. So if we follow a stepwise algorithmic approach, most patients can be managed. There are some patients who come in to the clinic for an injection because they want to avoid a surgery, and they are actually candidates for a surgery, and we just send them across. We said, look, this is not, so we don't have to pander to unrealistic expectations. A lot of times patients want to do physiotherapy because they want to avoid an injection or avoid a surgery. So this is where we need to kind of work as a multidisciplinary unit and get our brains together and use our strengths, because more now than ever we require to work together, because there is so much we've just become all fragmented because of COVID, and all of us are practicing in silos. So the whole idea, at least for us in an institution, it's easy because we have access to the sports team, the MSK ortho team, and wonderful people all around. But again, for therapists who are working standalone outside, this is the best time to collaborate and to get better results for our patients. And I'm sure I would just like to leave this open for any questions, any Q&As. If you want to raise hands, then we can take a few questions.
Live questions.
Everyone's done, we can move on.
The question, Mohini will answer that question for the dry needling, and then there is a part on the exercise which I will answer it.
Yes, please. Yes, please. I forgot that there are two parts to it. Yes.
Yes, I have treated patients with acute disc after I think 2 weeks with dry needling, and they get better with dry needling. Also, there was one patient with L4-5 disc with gluteal pain and lower limb pain. I examined, there was piriformis syndrome, and the piriformis syndrome I have treated with 3 sittings of dry needling, 1 week each sitting, 1 week apart. So he got better. He is good up till now. Two years back I have treated. So even piriformis syndrome also we can treat with dry needling.
Yeah.
So, going ahead on the same, continuing on the same answer for the same question. Yes, dry needling is one of the treatment factors of conservative management we do take, but ultimately it has to be supported by rehab. So we have to do the conditioning exercises. The exercise therapy is mostly conditioning, as you're saying, it is mostly conditioning. I didn't mention any specific exercises as such, what has to be done in the exercise program. I mentioned about types of exercises in my presentation. So, and what are the most evidence-based type is Pilates has come out to be the strongest leader in that kind of exercises, because the evidence to Pilates is quite supportive. Otherwise, other exercises like the movement control and yoga don't have a great evidence. But as you're talking about posture management, yes, posture management can be controlled by Pilates. So basically, as I said, I concluded in my presentation that it has to be looked as a whole body, not only the back. So if you exercise the back and the limbs in a balanced position, and you look after that properly, your posture will be managed, your strength will be improved, your mobility will be improved.
So just want to also kind of bring this to the attention that one of the topics that Dr. Vishal rightly mentioned, he discussed this concept of red flags. So whenever we assess the patient, of course, it's best to rule out red flags. Otherwise, we land up with patients who have a much more organic component to their pain, which could be an infection, a tumor, and so on. And we end up treating it. And that's one of the risks we run, especially with these pandemic times, because we have a very high threshold of kind of bearing pain. Our patients will keep bearing pain and they don't get investigated early and so on. So this is one of the other aspects of approaching these patients in the present times. Any comments, Dr. Vishal?
Red flags are very important. What happens is, especially with, I was a victim of the same when I started my practice 20 years back. We want to retain a patient when we start our practice. One. Second is everyone wants to please the patient. So nobody wants to say, okay, no, you're wrong. Majority of Indian patients would be very, very reluctant at whatever level. I operated 2 of my MS examiners. Both of them, one of them came with a foot drop. And other person came when he couldn't get up and go to his bathroom. So that is the level of, how to say, fear in orthopedic surgeons. So anybody else you can imagine the general population. But the thing is, you cannot sit on a very bad patient for a long time, because the physiological loss, what people used to call stamina in good old days, I don't know what, they're all new terms for everything. Once a 60, 70-year-old, when post-menopause or post-andropause, loses muscle mass, it is extremely difficult to build it back. It is very difficult to build back a physiological function. And modern medicine ensures that you don't die early. So this time of starting of journey downhill to the time when it is over can be very bad for a patient who's got deconditioned because of a pathology. And then they become homebound. Then they say, "Arey, maine itna ilaj karaya, take me home." So this was a person who couldn't get up and go to the bathroom. He's not going to run a marathon at the end point of his treatment. Other thing they don't understand is that rehabilitation is equally important. In fact, more important than the primary surgery. Everybody thinks, मैं 10 दिन physio करूँगा, ठीक हो जाऊँगा. The whole old concept की shortwave ले लो, ultrasound ले लो, it doesn't happen. I warn all my patients, you're going to require at least 6 months of rehab. You may require 10 to 20 visits during this time. It will not be every day. And what exercise, doctor, आप exercise लिख के दो. That's another thing we get to know. The thing is, it's like, at least I tell it from my side, no therapist tells me how to operate. So I'm not going to tell you a therapist how to do a rehab. Each one is a different person. They will take care of you according to what they feel is the best. You need to have a plan. If you have surgeons ticking off, I think once you should be telling, I have my wife who told me this once. Do you take advice from me how to operate? No, so stop giving advice to my friends how to do rehab. So you need to tell your referring ortho or neuro that, okay, leave the rehab to me. I have seen prescriptions with 10 ultrasounds, 10 McKinsey repetitions, and 20 shortwave. That's gone. I think those are like, other thing is there is a lot of, the other end is aggressiveness. I see people like the North American Spine Society has said 7 days of restricted activity and only 3 days of bed rest. I mean, North Americans are a little aggressive. They're all Donald Trumps when it comes to their treatment. So we need to take a middle path. We have to understand that when you get a herniated disc, it takes at least 3 to 6 weeks for the body's healing to kick in completely. That's the reason you are in pain, you have spasm, your mobility is restricted, because it's the body's mechanism which is trying to let it heal and avoid stress on it. A fibrosis of the disc, the desiccation of the disc starts at 3 to 6 weeks. But this doesn't mean you have to be in bed at that time. You have to keep the patient mobile, but you don't have to put him through the whole exercise regimen so that you will ensure that it pops up. In spite of doing everything correctly, there will be people who will deteriorate on rehab and come down. But by going very aggressive or by not going aggressive, we are ensuring that this patient is going to come to me for surgery. So somewhere, again, I guess middle path is always better. Aggressiveness at both ends is not the correct thing. And especially for private practitioners, it's very difficult. I see a lot of my patients saying, "Hey, doctor, वो physio के पास हर रोज जाएगा, मेरा therapist का घर इतना दूर है, अभी COVID में society में entry नहीं देता." I think most of us should be getting online now, on online platforms, and see to it that we hold regular group therapy sessions. You will have a pool of patients. You should have group therapies where that increases their involvement. वैसे भी public घर पे बैठा है. At least that keeps your patient base intact and gives them some help in form of having done the particular group exercises every week, I guess.
So,
sorry.
Go ahead.
Exactly. Just supporting Vishal's this thing comments, what he said about group exercises. It's guideline again, as nice guidelines also say that group therapy sessions or individualized therapy one-on-one sessions are the way ahead for exercise sessions, and they have to be done. The exercise have to be followed. And one more thing I wanted to add, as Vishal said, about after age of 60, the muscle mass reduces. Actually, the muscle mass starts reducing at the age of 40, and by 8%, and which doubles at the age of 60 to 16%. So usually early in life, if you start exercising and maintaining your muscle mass, it will be much healthier for every person.
So I'd just like to thank them once again, and I've got only last 2 closing comments. Moini, you want to say something? All right. So just 2 closing comments. One is, of course, whatever you do for your patients, even if you're doing it online, please charge them for it, because it's your professionals. Don't value your time, value your expertise, and value the contribution that the team has. And thanks to all of you for attending this. And the last part, the closing comment, is that I'll head to start doing exercises for my own low back, because I didn't know that after 40-hour back muscle mass starts reducing. So I'm going to take care of that 8% loss. And thank you for attending this. So all of you will get just a small little summary of this. I'll try and see if I've recorded this, and I'll see if I can put it up on one of the platforms here. So thank you for taking time off. I think there's one last question. Okay, there's a thank you from Dr. Suchita Deshmukh. Thank you. Yeah.
Thank you.
Thank you. Thank you very much. Have a great day.
Please be safe.
Great weekend.
Yeah, take care.
Thank you, Dr. Mahesh.
Bye-bye.
Thank you, Dr.
Thanks,
Vishal.
guys.
Thank you
very
sir.
much, everybody, to attending. See you all.
See you. Bye.
Take care and stay safe.
Take care.
Thank you, bye.